Thanks for joining the IRPP today. I'm Colin Busby, Research Director of the IRPP, and I'd like to begin by acknowledging that I'm broadcasting to you from the unceded Indigenous lands of the Kanien'kehá:ka Nation. Tiohtià:ke, Montreal, is historically known as a gathering place for many First Nations. The COVID pandemic has brought to light many challenges in delivering long-term care services to Canadians across the country. We've witnessed with shock the reports of neglect, suffering, and pandemic-related deaths in long-term care homes over the past year, and we know that provincial and territorial policymakers must improve the quality of care in long-term care homes across the country. But these struggles have likely reinforced the desire of many Canadians to age in their homes as long as possible. So we must also confront the need to move away from a heavy reliance on institutional care in Canada by expanding options for long-term care services delivered at home. Other countries have been more active than Canada on this score, with over half of OECD countries offering cash for care schemes, which are cash transfers to long-term care recipients that give them more autonomy over the organization of their care and help them address unmet care needs. But are these policies working, and could they be better adapted to the Canadian context? We have with us today the author of a recent IRPP study on the subject, Colleen Flood, as well as two other experts in the field. Thanks, Colleen. Ito Peng and Isobel Mackenzie, who will be discussing the study and reacting to its findings. After these presentations, we will have a short discussion and answer questions from the audience. By way of introduction, Colleen Flood is University Research Chair in Health Law and Policy and the inaugural Director of the Centre for Health Law, Policy and Ethics at the University of Ottawa. Ito Peng is Professor of Sociology and Public Policy at the University of Toronto. Isobel Mackenzie is the Province of British Columbia's Seniors Advocate, and she has over 20 years experience working with seniors in home care, licensed care, community services, and volunteer services. With that, over to you, Colleen, and we look forward to the discussion later.
Well, thanks very much. Colin, can you hear me just fine? I'm assuming yes.
We can.
Okay, great. So good afternoon, everybody. And thanks to you, Colin, for both the support with writing the paper and for organizing this event, and to the IRPP and to my two panelists. I'm very pleased to be here with you today. As Colin mentioned, COVID has really brought to light a number of long-standing problems in Canada's long-term care system. And I think the sense that reform has been needed has been known, at least for the last 2 decades, with report after report. And then with depressing regularity, media exposés across the country, telling stories of shocking neglect and maltreatment in nursing and retirement homes pre-COVID, occasionally pointing to underlying systemic causes, an over-reliance, as Colin said, on costly institutional care, lacks quality and safety regulation, an intensifying acuity of need amongst seniors who have no alternative but to remain in the system. And COVID crashed into this already broken system, exposing its many abject vulnerabilities. Without major reform to long-term care, then we are going to face some very significant fiscal challenges going forward. Canada's population is aging, as we know, over the coming decades. A report by my colleagues, some of my colleagues with the National Institute on Aging, projects that long-term care costs will more than triple in real dollars by 2050. Eating up nearly 20% of revenues from personal income taxes, federal and provincial. Lower fertility rates and socioeconomic shifts are projected by my same colleagues, Bonnie Jean McDonald and Michael Wolfson, to bring a 30% reduction in the availability of unpaid caregiving over that same period. So we really do have a very distinct fiscal and policy challenge in this space. Just to keep what we have is going to require very significant investments. And I think everybody is in agreement now that we must improve the quality of care and the quality of life itself for people at the end of their lives. So going forward, a review of the literature, and I think most people on this call will agree that investments are required in 3 related areas: First, significant new investments in long-term care facilities and workers. Second, investments in formal home care so that more people can age in place. And then third, support for informal care providers, including respite programs, time off work, cash benefits, cash for care benefits, and training. And it's this possibility of expanding cash for care benefits that I'm speaking to today and our paper. And I want to acknowledge my colleagues who worked with me on this report for the IRPP, funded by a CIHR grant. Deirdre DeJean, who was a research associate with us, now with CADIT. Lorraine Friesner-Dota, who is a professor of political science at Bremen University. Amélie Kernel-Vallée from McGill University, also a political scientist. And Eric Schutt from Erasmus University in the Netherlands, an economist. So first, what are cash for care payments? In a nutshell, this is where instead of providing formal professional services, a government or other payer, could be a private insurer, pays instead a cash payment directly to the individual in need of home care. That individual, the care recipient, can then spend this cash on the care they need. The size of the cash payment is calibrated to the needs of the recipients. Higher needs receive higher payments, and needs are periodically reassessed. Now, a major advantage of a cash for care payment, as you'll see immediately, is that it gives more autonomy to patients and provides flexibility for them and their families, enhancing their home care options. Rather than being stuck with a bureaucratic assessment of how many showers one receives a week, for example, a cash payment enables a person to pay for the care that best suits them. Often cash payments may be used in part to support supply of labor by what would be otherwise unpaid caregivers, wives, daughters, sons, daughters-in-laws, friends, and so on, who provide care in the home. Depending on how flexible a cash for care scheme is, it can also mean that if someone has, for example, someone already providing informal care, instead of buying care per se, they might want to invest the cash in putting in an accessibility ramp into their house or making their bathroom more accessible, or perhaps as simple as paying for snow removal from the front of their house, the only thing they may not be able to do, but without which they cannot stay in their own homes. So you can probably see prima facie the immediate appeal of this kind of policy. And indeed, around the world, as Colin mentioned, it is very popular with half of OECD countries embracing this in some measure. And as part of the research program that was funded by CIHR, we wanted to explore this phenomenon of cash for care and its possible applicability to Canada. And we noted that its particular popularity in both Germany and the Netherlands. And first, an interesting contrast that a much lower percentage of GDP is devoted to long-term care in Germany than the Netherlands. So we were interested in that comparison, despite them both having universal plans for long-term care. And an important part of departure between these two countries is how strictly cash benefits are regulated. In Germany, there's virtually no regulation, and a care recipient can truly spend the cash on whatever he or she desires, although there are periodic checks to make sure that the person is faring well, healthy and faring well. In the Netherlands, cash payments are a much more regulated affair, with the requirement that if one is hiring a family member, for example, that there is a formal contract in place relating to the provision of the services. And these formal contracts are kept in a sort of central database. You can download them and they're very easy to do. Doesn't require a lawyer. That's probably a bad thing. And perhaps in part because of this light regulatory oversight by the Germans, some 52% of German recipients of long-term care opt instead of taking professional services to take the benefits in cash. And so this means that cash for care accounts for 26% of their total long-term care budget. In contrast, in the Netherlands, it accounts for about 10% of the total long-term care budget. So I hope by this point to have persuaded you of some of the significant possible advantages of cash for care. But I want now to complexify the debate a little bit by talking about some of the concerns. Now, in doing so, I don't want to convey to you that our group is opposed to cash for care policies, but we do think they need to be implemented thoughtfully and carefully so as to maximize the benefits and minimize the problems. So let's quickly some of the problems that emerge with cash for care, and we can then think about how to attenuate them in the Canadian context. First, cost savings. Canadian governments or folks involved with Canadian governments are often very interested in cash for care because of the fact that normally when cash is paid rather than formal home care services, the idea is that you give a percentage of what it would cost the government to provide the professional services. So it would be 70 or 80% of the normal cost for the government. That's what you would receive as a cash benefit. So it holds this allure of potentially being a cost-saving measure. In reality, though, there's a lot of potential moral hazard here. I, for example, would very much love to have someone clear my snow and clean my house whenever possible, really. And so you have to be aware of the possibility that more people will, as I say, come out of the woodwork seeking these benefits when perhaps they've had other ways to have their needs met in the past. There's also the possibility of fraud here and concerns about this, and the rising cost of the cash for care program in the Netherlands has resulted in that government trying to restrict the cash for care option to only those people who would otherwise have been institutionalized and so on. They were unsuccessful in that regard, but you can see they were the imperative for them to move as the cost of the program was increasing significantly. So there may be very important reasons to provide cash benefits to support the work of informal caregivers and to give autonomy and choice to care recipients. But it seems unlikely from what we see that governments will save money, and they need to think of it more as investing in informal care. A second concern is quality. If we are thinking about increasing the percentage of care that is provided by informal caregivers, then of course we may need to consider and contrast the quality of care that can be provided by professional caregivers as opposed to informal family members and friends. Interestingly, though, a study from the Netherlands found that the cash benefits program was of the greatest benefit to the chronically ill individuals with complex care needs. And they viewed this program as much more successful and helpful than, for example, home care providers themselves or health insurers. Both home care providers and health insurers themselves expressed concerns about the quality of care. And just to give a poignant example, the worry is, how do you fire your daughter-in-law or your son-in-law if they're providing informal care services and the quality of care is not high enough? Now, to some extent, this concern may be alleviated by periodic check-ins with a care recipient to ensure that their well-being is fine, and with more frequent check-ins depending on acuity. So that's those first two problems are ones around, are we really saving money? And one's around quality. The third problem is perhaps more complex, and that's around the issue of gender. Women make up a far greater proportion of the very elderly, and women provide more informal care than men over their lifetimes. At least that's the current state of play. A system of cash payments will provide women with more monetary support and provide recognition for their informal work. However, if a cash for care system encourages more working age women away from formal employment to provide informal care, then that could be a serious problem, making it more difficult for women, for example, to save for their own retirement, and could have larger economic reverberations. So when we consider the impact of a cash for care scheme in Canada, we should take account of the fact that while a similar percentage of women work in both Canada, Germany, and the Netherlands, in Canada, some 74% of women work full-time compared to just 63% in Germany and 42% in the Netherlands. And as we think about putting more emphasis on informal care supported by cash for care, we must consider this gender impact and the longer-term economic effect of such models and whether they will drive more women to working part-time. An important part of the cash for care model in both the Netherlands and Germany is the provision of other kinds of benefits to support informal home care workers. For example, a family member in Germany who provides at least 14 hours of care per week and otherwise is only employed 30 hours elsewhere receives coverage of social security contributions. So, for example, in the Canadian context, contributions for CPP and so on, as well as vacation care, vacation pay and respite provisions. And these kinds of additional supports, we think, are critical to making sure and supporting more informal care and that this does not exacerbate further gender inequalities. Our final concern with cash for care is the rise of grey markets for migrant care workers. In Germany, cash benefits have spurred a grey market for caregivers where families use the money to hire untrained non-family members, often Polish women, to provide this care. They're often called upon to provide the kind of 24-hour care for Germans that would be too expensive to purchase in the local market, and if provided by non-migrant workers, and too impractical and inconvenient for family members to provide directly. In contrast, in the Netherlands, various regulations seek to deter the use of grey markets. For example, the formal contracts that I mentioned before between care recipients and others have to be used to spend down the cash transfers. One response to this problem is obviously to legitimize and properly regulate migrant workers. In the Canadian context, this issue should spur a discussion of expanding the Home Support Worker Pilot Program, permitting migrant workers to immigrate as caregivers and eventually to apply to become permanent residents. So I'll conclude here with noting that cash benefits, we think, hold the promise of being part of the solution for financing and delivering long-term care to Canada's aging population. These benefits can compensate for some of the shortcomings of formal home care services and empower people to organise and manage their own care according to their own needs. Canadian provinces, following the lead of many OECD countries, could integrate cash payments with appropriate regulations, but international experience also speaks to the need for caution. The uptake, satisfaction, and effectiveness of cash benefits will depend on the regulations directing how the benefits are accessed and spent. Inadequate regulations could lead to major increases in public spending, and we need to carefully monitor the gendered impact of a greater societal emphasis on informal care. Additional supports need to be provided to those who give up formal employment or go part-time to provide informal care, such as CPP contributions, vacation pay, and respite provisions. So I'll finish there, Colin, and I really look forward to the discussion.
Thank you very much, Colleen, for a great introduction to the topic and really setting the stage for our ability to dig deeper into it later. Ito, now I'd like, oh, great, wonderful, there you are. It's over to you, your thoughts and reactions to what Colleen had to say.
Thank you very much, Colin. And Ricardo, I wonder if you could share my PowerPoint on the screen, please. Thank you. So thank you very much for inviting me to read and comment on Colleen and her colleagues' report. I just want to say, first of all, this is a really good report and I really enjoyed reading it and I highly recommend people to read it. What I would like to do in the next 10 minutes or so is to discuss some of the points that were raised in the report and in Colleen's presentation now that I think are very, very good and that I agree with, and then consider my take on this report and raise some questions for Colleen. So next slide, please. There are many things in this report that I really like and I agree with, but here I'm just going to point out four of them. First, the report is absolutely right in saying that our current long-term care system is flawed, and that it needs a serious overhaul. And by this, I would like to add that it cannot be just some kind of cosmetic changes. It has to be broader structural and systemic reform or reforms. As the report points out, we need a more coherent, effective, and quality long-term care systems that would address a continuum of care needs from home-based to institutional care. Our current long-term care system tilt toward institutional care needs to be sort of corrected and balanced by more home-based care. And here again, I would also like to add that in addition to home-based care, community-based care as well. And it's worth pointing out here that we need to look at long-term care reform, not just in relation to long-term care homes or home-based care, but rather from a larger systemic point of view. Third, I also like the fact that the report looks at other countries' experiences to draw lessons. And on that point, both Germany and the Netherlands are really good examples. There are a number of reasons why these two countries are useful examples for us. First, they are both OECD countries like Canada, except that their populations are a bit more demographically advanced than ours. For your information, the proportion of population over the age of 65 in Germany is now, about 22%. The Netherlands is about 20% compared to Canada, where our 65 plus population is about 18%. But by 2040, the 65 plus population in these countries are projected to reach to 29, 28, and 24% respectively. So over the next 2 decades, all these countries will get much, much older. Germany and the Netherlands are also good examples for us because they are early introducers of universal national long-term care insurance. They both introduced universal mandatory long-term care insurance because they understood their demographic futures and were concerned about the implications of the long-term care as their populations aged. So they decided to take action to address this. And I think this is something we can really learn from. Finally, Germany and the Netherlands are also very good examples for us because their long-term care insurance system offers cash for care options. Though, as the report points out, they are configured, these cash for care options are configured and managed slightly differently from each other. Next slide, please. So now, having pointed out good things about this report, I want to say a bit about my take on this report and maybe a couple of additional points for consideration. Here, I want to sort of focus on 2 points. First, the examples of the Dutch and German long-term care insurance discussed in this report tells us a few important things. One is that long-term care insurance is a compelling option to address long-term care needs of an aging population. This is because, as Colin pointed out, a universal long-term care insurance not only provides a clear and organized system for financing and delivering a continuum of care, but it also creates a financial channel that's dedicated to long-term care. I think this is really important because, as we saw in Canada, having to rely on general tax for funding long-term care is extremely insecure and unpredictable. And in most cases, this would lead to a chronic underfunding. So long-term care insurance is is compelling, but it's also compelling because it offers a package of financial and service arrangements for older populations. So as the examples of the Dutch and German long-term care insurance show, the cash for care option is one of the components within their long-term care benefit package. In fact, if you look at the world of long-term care insurance, you see that it comes in many different shapes, size, and configurations. And they're rightly so, because long-term care insurance has to fit the socioeconomic and cultural context of the countries in which they are based on. And this is, and so it just so happens that in the case of Germany and the Netherlands, the policymakers decided to include cash for care as an option in their long-term care insurance because they believe that this option would address the unique needs of their population. So as the German and Dutch long-term care insurance illustrates, long-term care insurance is highly customizable. And on this, I think we should cast our net a bit wider and look at other long-term care insurance models that might be adopted, that might have been adopted within the OECD. So it turns out there are two other countries that have also adopted universal long-term care insurance, which is Japan and South Korea. And both of these countries have actually drew lessons from Germany and the Netherlands as they develop their long-term care systems. By the way, France is now debating about long-term care insurance as an option for their national long-term care, But what's interesting about Japan and South Korea's long-term care insurance is that they both rejected the cash for care option for fear that first, as the report points out, it will reinforce women's familial care obligations and justify women's low-wage care work. And secondly, that they rejected because cash for care option will further raise barriers for women to enter the labor market and block their career path. In fact, in the case of Japan, women's groups were dead set against cash for care options. And because of their strong objections, the governments actually dropped the cash for care as an option entirely. So as the report points out, if we were to customize cash for care option in Canada, we will need to weigh the costs and benefits of this option very carefully. And in the case of Canada, in addition to potential barriers for women's employment and career path, we would also need to consider its potential to exacerbate the use of migrant or immigrant or racialized women in personal and or living long-term care work. This is one of the concerns that Colleen has also raised in her presentation in relation to Germany's long-term care insurance cash for care model. This then points to the fact that regardless of whether we adopt cash for care option or not, regulation is important. As the cash for care options in Germany and the Netherlands illustrates, when they are poorly regulated, they can lead to perverse incentives and market failures, which in turn can result in poor quality of care and questionable employment practice. Next slide, please. So finally, I just want to raise 3 questions to Colleen for this excellent report. My first question is, I would love to know more about how you would implement cash for care options in long-term care systems in Canada. For example, would it be a universal national program, or would it be more provincial, regional specific program? Second, I would also like to know what would be the best mechanism or channel to fund and implement cash for care option. Would it be a new standalone program, or would you consider it as a part of a universal long-term care insurance like Germany or the Netherlands? And if yes, how would that be financed? And then finally, how would you regulate cash for care programs to ensure access, equity, and quality of long-term care for Canadians? And with that, thank you very much. And I would love to hear the responses.
Thank you very much, Ito, and some really good questions at the end too that I might take the opportunity to pose to all of the panelists when we're done and when Isobel has a chance to present. So I know you have thoughts there as well. So Isobel, great, wonderful. Over to you, your thoughts, your reactions.
Thank you, Colin, and hello et bonjour to everyone I'm speaking to you from the traditional territories of the Lekwungen speaking people here in Victoria, British Columbia. I echo Ito's comments that it is an excellent paper, and as a geriatrician, I have followed Colleen's work for many, many years, and I very much appreciate the opportunity to read her paper and to comment on the paper. And I'm going to give the perspective really that reflects a background of having worked with this particular population in both settings, in long-term care and in home care, and now in the policy realm of geriatric care to our population. And one of the things that we've created in Canada, for the most part, and certainly here in British Columbia, when it comes to long-term care, is that we have incentivized financially the recipient of the care services to go to long-term care. Even though it is financially better for them, it is financially disadvantageous to the funder, meaning the taxpayer. We pay more in long-term care. We subsidize that to a much higher degree than we subsidize our care in the home care setting. And we see that reflected again and again and again in the data. And in the paper, Colleen has referred to the fact that about 20% or 1 in 20, or pardon me, 1 in 5 long-term care residents have conditions that are minor enough, both cognitive and physical, that they could be living successfully in the community with some help. Now, what we know here in BC is that that number is even higher. And we know from our inter-eye assessments that something in the neighborhood of almost 7 out of 10 people who are admitted to our long-term care nursing home system have had no home supports 90 days prior to their admission. And we know that our rates of residents with mild cognitive and physical functions is in the order of magnitude about 10% higher than the national average. Part of that is explained by the British Columbia decision to charge for public home supports. So we've created a bit of a zero-sum game. The maximum subsidy you can get is to move to long-term care. If you stay at home and receive the publicly delivered home support services, we even charge you for that. So even more reverse of cash for care, we charge you for the care you receive in your home, and we don't charge you for the care you receive in long-term care. So that's an interesting financial incentive that we have in British Columbia, and I think that you see in the data that it has an impact. When we look at the concept of cash for care, there is an element of this policy at play in every province in Canada. In BC, we call it our Choices for Supports and Independent Living, and it has focused for the most part on the younger disabled community, where they are given funding in order to provide the care for themselves. In large part, it originated as a policy that was based on helping younger people remain active in the paid labor force despite their high level of disability. Over the years, that has crept into our geriatric population, although it's not widely used and it's very bureaucratically cumbersome. But we do find that the people who use this client direct funding have a much higher level of satisfaction, much lower caregiver distress, despite having higher care level needs than those who receive the traditional home support, where the government is basically delivering the home support on an hourly scheduled basis to your home. So we have those indicators that tell us, yes, again, further to what Colleen's study spoke to around higher levels of satisfaction for those who are able to control who's providing the care, what care they're providing, when they're providing it, all of those levers of autonomy that are missing when you take the care through the government system and are absolutely missing when you accept the care in the long-term care system. Now, I think that what is also important, however, to recognize is that money is part of this, but even if we solve the money side of the equation, we still have a clinical culture that pushes people to long-term care. And I see elements of that woven a bit through the paper. So we will often encourage people to go to long-term care because we believe it is a more safe place for them to be than at home. And certainly we've seen in the pandemic, that's not always true. And anybody who's worked in long-term care will tell you that you can miss your medications, you can have a fall, you can develop pressure ulcers, you can develop an infection, you can succumb to depression and weight loss in long-term care, just as you can at home. And so this idea that it's risk-free in long-term care really hasn't materialized, but we convince people that it's the better place for them to be. And so we're going to have to overcome that culture a bit as well if this is going to realize its full potential. One of the issues that was raised in the paper, and Ito spoke to it as well, around the concern of cash for care benefits affecting women disproportionately and impacts on labor force. I actually don't share those concerns. And the reason I don't share those concerns is because if you look at the paid labor force right now in long-term care, delivering care to elderly Canadians, it is overwhelmingly female and overwhelmingly lower wage paying jobs. So which group are you going to burden with that? Because if we're concerned that it will mean family members will provide this care for their family, they'll take themselves out of the paid labor force, they'll lower their wages, that's already happening within the paid labor force, within the long-term care and the home care sector in Canada, and we absolutely need to address it. My other observation is that you will probably find, and this certainly was my experience, is that people tend to sort themselves out. So those women who want to be in the paid labor force, who do want a career in the paid labor force, they would elect to take the cash for care benefit to hire somebody, not to exit the labor force themselves to provide that care. Those who are most likely to exit the labor force in order to receive the cash benefit to provide the care directly will be those for whom, in fact, the parallels between their economic life in the paid labor force versus their economic life in cash for benefits, it's not going to necessarily be that different. And we also have to take a look at the totality of time that we're speaking of. Usually by the time you're taking yourself out of the paid labor force to pay for your adult family or to care for your adult family member, it's for a limited period of time, much more limited than you might take yourself out of the paid labor force, for example, to care for your children when they're young. So I'm not as concerned about that as the concerns raised in the paper. I also, when it comes to the issue of immigration, again, from a practical experience, that is who is providing the professional paid care right now to a large extent in Canada, particularly in the provinces of Ontario, Quebec, British Columbia, to a lesser extent, Alberta, Saskatchewan, et cetera. And so again, we're going to have to grapple with this. Canada needs immigrants outside of healthcare. We need immigrants in order to grow our country and in order to grow our labor force as our dependence ratio shifts and we have fewer paid people in the paid labor force and at the retirement end of the spectrum. So I think that again is an issue where we want to be careful that we don't look at other issues relative to equity and justice and transplant them into this sector as a way of minimizing the full potential of this program. Because I think on balance, when you look at the data of who is in long-term care, when we look at their cognitive function, their physical function, their family function, and when we look at their socioeconomic structure, really what we're talking about is a good system of allowing families to receive the funding to a high percentage that we would subsidize them for in long-term care, could possibly divert between 10 to 15% of admissions to long-term care each year. It's not going to transform things, but what that diversion will do is allow the growth in the population that's occurring to be more readily absorbed within the infrastructure that we have for a period of time. We're still going to face the need for more infrastructure, and we certainly need better infrastructure within what we have right now in Canada. But Colleen was quoting the estimates from Bonnie Jean and the NIA about the future cost of care. And I think that many of us now realize, certainly with what has happened during COVID and the promises made by governments, that's going to be much higher because we're going to have more care in long-term care, and the care we're going to have is going to be paid more in long-term care. So even if everything else remains constant, I think those numbers are going to grow exponentially. So we really do need to wrestle this, I think, to the ground. And looking at countries, and I'm glad Ito raised the Japan long-term care insurance, because of course Japan has one of the oldest populations in the world, and looking to them and how they have managed on their long-term care insurance and the sort of the choices that people have and make to support them in the aging process, I think is going to be the way forward. And I'm going to close with sort of the questions that I have for Colleen, and they parallel to some extent the questions that Ito has raised. But of course, Netherlands and Germany did this at a national level, and we have a federated model in Canada. And so I would be interested in Colleen's perspectives on how this would look in Canada. What exactly could the federal government do that would make a cash for care benefit program applicable in the same way in all provinces? I would also welcome Colleen's insights into how will the cost sharing work between the person receiving care and the government funding the care, and what are her thoughts on what is a good balance or model there. And segueing into that would be, when we're deciding what our contribution is, we can do it through the general tax system, we can do it through an insurance premium scheme, and also what we're expected to pay. Every jurisdiction in Canada, whatever they do on ability to pay, is only income tested. Where does asset testing come into play, particularly as we see future generations of retirees having significant amount of wealth in assets, mainly in their principal residence in our major cities? And to what extent is it reasonable to look at guaranteeing people a level of funding to ensure that their assets, that they can draw down their assets, and then government will step in when that's happened. So I'd be interested in Colleen's thoughts on that as well. So, and I will conclude with that, and thank you.
Thank you very much, Isobel. Why don't I invite everybody to join us? Colleen, Ito, and Isobel. That was those are really trenchant comments to leave us off on, Isobel, because those are really important issues that you raise. So, often, I planned as moderator a few questions to ask the group, but you've just done part of my job for me. So why don't I just pick up on one of those questions, and Colleen, I'll prepare you for this, because I think it's an important one. It was the first one that Isobel mentioned. It's okay. We need to reform long-term care in Canada. We've got some ideas. How do we go about sorting out some of the interjurisdictional challenges between the federal government and the provinces in terms of who should do what, and how those roles should be sorted out in a way that maybe makes sense, and gives us the opportunity to make change. So why don't we just go directly with that one to you, Colleen?
I really should charge for these answers, I think, Colin. So we've gone past cash for care to reforming the whole of long-term care. So I just want to make clear that our discussion of cash for care, some of the questions coming up in the Q&A sort of seem to assume that we were suggesting that this is the only thing you would do in long-term care, and that is not the case, right? So this would just be part of a system, our current system, where we have public funding for long-term care institutions, some public funding for home care, professional home care, we all agree that needs to be more, and then informal home care. So the cash for care payment would be part of supporting that. So I just want to make sure that we're all on the same page with our discussion, that we are not trying to, and in fact, where we get to in the paper is that we think there is a modest role for cash for care. We are more in the Dutch camp than the German camp. So perhaps as between, Ito and Isobel, we're more in the Ito camp than the Isobel camp on how far one should go, because we do have concerns about the gender impact in particular. And we would also note that there are variations of these cash for care ideas that are happening in provinces across Canada, but in most of the provinces across Canada, except I believe Nova Scotia, the payment isn't made to the care recipient, but arrangements may be made payments can be made to the care provider, right? So direct to the care provider. So it's a different idea from empowering the individual, him or herself, to kind of direct their own care. And that's kind of what we were being interested in. Nova Scotia has one where they do actually provide someone who is heavily disabled and below a certain income line. They give them a cash payment and they can spend it as they wish. And it's got pretty good results in terms of feedback on how that's gone and etc. But it hasn't been expanded past that. So I just wanted to make sure we were on the same page. But, I get it. Like we need to reform the whole of long-term care top to tail. All of those three things need improvement, and they need significant investment of money. As I tried to convey, just to stay still, we are going to need to find a massive amount of dollars, or the burden is going to fall so terribly on the people who need care and on the people who have to try to provide that care and scratch it together somehow. It's going to be awful unless we do something fairly magnificent in this space. So with our cash for care idea, this is certainly something that provinces can, and I know that many of them are quite interested in this idea. Sometimes I think perhaps for the wrong reasons. As I mentioned, they think they're going to save money. I don't think they're going to save money. But if they want to do it to really support informal care and they want to make that kind of investment, then I think this is definitely a piece that they could embrace, subject to all the caveats that I had before. And so, normally healthcare is typically viewed as within provincial jurisdiction, and this is certainly the case for long-term care. However, we have a massive fiscal challenge here. The provinces are already spending, many of them, close to 50% on healthcare. Talk of any new programs give them the heebie-jeebies, whether we're talking pharmacare, long-term care, dentistry, even expansion of physician and hospital services. None of these are pretty discussion points from the provincial perspective. They're just so busy treading water just to stay where they are. So, don't come at them with any massive new spending programs. It seems to me that if we wanted to reform, and I think we have to reform long-term care tip to tail, we need the feds on board. We need them to come up with a plan and to try to get the provinces and territories on board. It will require a lot of money, and the federal government are really the place that money has to come from. It can't come from the provinces, as far as I can see, or only a very little amount, some moving things around here and there, some patchwork pieces. So if we end up with the patchwork pieces, Cash for Care could be part of that. But I'm much more of an advocate now, all of us having lived through the atrocities in long-term care in Canada. I couldn't believe that could ever happen in Canada, and it did. That we have to reform this whole thing. Ito has raised, and the point has been raised, well, where do we get the money from? There are different ways to skin this cat, and Germany and the Netherlands show different ways of doing this through using social health insurance. So that's where, we contribute a percentage of our income. Sometimes our employers might contribute as well into a central plan. And we may not need it. Many of us will not need long-term care. But for those of us who do need it and need it 24/7, then the funding would come from some sort of social health insurance plan. I think that's an option that we really should look at very closely, because I think whereas most of us are not too happy about paying more taxes, many of us are happy to pay taxes if it's actually going to something like long-term care or home care. So I do think that that's a promising avenue, but I have been saying that for about 15 years and no one's been listening to me so far. But maybe this is the moment, you keep working away at these things and then eventually poof, a window of opportunity opens up and the stars align and we can really make a run for a new vision for healthcare for Canada, which, I think that is an option. So sorry, a very, very way too long response, Colin, and I will be quiet now.
Thanks, Colleen. No, there was a lot of context there, and there was a lot of, it is hard to sort of always situate an idea within the broader scheme here. And we are talking about, long-term care as a big program. It has many dimensions to it. So it's hard to sometimes deal with the forest and the trees at the same time. But Ito, why don't, Colleen sort of ended with the idea of financing and the financing models and how integral they are. And Isobel touched on that as well, how integral they are to sort of kickstarting reforms. Now, to keep a little bit as well some of the ideas with respect to the challenges in the federation, what really caused these countries to sort of to change that you mentioned, and you mentioned Japan and Korea following Germany and the Netherlands and learning from that. So what was it that they really gleaned from those models and learned in terms of adapting it? And in the same breath, if you can, we're late to the party here, right? So we're really late in the game. How does that change things for Canada as we reflect on what our financial options are?
Yeah, thanks very much. Listening to Colleen's description, I totally agree. First of all, that what we need is a real total systems overhaul, right? So it's like Cash for Care is one segment, but we've got lots to do, and we need to do that entirely. And I'm assuming Colleen, when you say social health insurance, you mean long-term care insurance type of insurance, right?
Yeah.
Okay. So
those other jurisdictions, as you know, they finance their healthcare as well as care through social health insurance.
Yeah. So just by way of answering Colin's question, all these countries that have introduced long-term care insurance or social health insurance really were interested in sort of a couple of things. One is, of course, they knew their demographic future, and they knew also the implication of that demographic future in terms of the care needs and the financing part of that care needs. And so, for example, when Japan began to discuss long-term care insurance, do you know who was the main driver of that? These were government Ministry of Health and Welfare people. They were saying, oh, look, here we have aging society. The cost of the healthcare for them is very, very large because of all the social hospitalization and institutionalization of long-term care. What if we could find a different sort of mechanism, channel to provide needed sort of the long-term care from home to institutions at a much sort of more sort of manageable financial scheme? They said, well, why don't we develop a long-term care insurance in which that premium, that funding will be dedicated to long-term care. So we could actually take that out of the medical care sector and then create new channel for long-term care. The way they financed it is, I think, has lots of possibilities. In the case of Japan, they find about 50% of the long-term care insurance is actually general tax. About 30% is the insurance premium, and another anywhere from 10 to 20% is co-payment. So they're kind of arranging this. They thought that this would be most, this would be most sustainable, manageable, and at the same time have sort of equalizing potential. And so I think and what happened in the case of Japan was that, Japan is one of this very conservative society in which people hate paying tax, but almost like over 80% of public supported this because they knew exactly where the premium was going to go, where that tax was going to go. So having that sort of dedicated premium tax line, the insurance model really works, I think. So it's a quick way of saying, I think having that dedicated funding mechanism can really assure public that this will go into long-term care system.
Thanks, Ito. Isobel, I'm gonna set you up with a question here next, and here going forward, panelists too, if you want to jump in on anything, just put your hand up, and I'll make sure that you get to jump in on it. But Isobel, and this kind of relates a little bit to what Ito was saying about having a unique financial entity or channel being distinct from healthcare, being distinct from social services, in the sense that we've been talking about, directing more resources away from institutions into home care for what seems like decades now. But we've made very little progress in doing that. And that's kind of one of the innovations of Cash for Care, is to kind of smooth that channel, help it along. There's the flexibility component too, but there's that, okay, well, how do we make that transition? So what are your reflections on why, this has taken so long, and why it's so difficult to move the deck chair, so to speak, to better balance out where we spend long-term care across, spectrum of needs?
I think a big part of it is this old adage about don't let perfection be the enemy of progress or the good, right? So, Colleen's paper raises a number of issues. How do you know quality of care? How are you, this issue about the role of women in the labor, who's it going to impact? And when we raise those, which are legitimate concerns, although you've heard my perspective on the female participation in the labor force issue, but what that does is that allows those who are heavily invested in the status quo to maintain it, right? And who's heavily invested in the status quo? For the most part are governments, because do something, do nothing, nothing has less risk. But I think the other thing that is underappreciated in Canada, because we pride ourselves on, we're the land of free healthcare, but in geriatric care, there is significant private interest and significantly large players in providing what is the status quo, whether that is the long-term care model as we have it, or in some provinces, not all, the provision of the home care. And, I was on a panel the other day and was talking about the necessity of, the rising wages will grow the labor pool, and you'll have more choice, and the quality will, all the labor economics theories. And one of the panelists was quite adamant that because that's what the providers could do. As a long-term care operator, it's within my power to offer higher wages. But no, what we want to do is turn it over to the federal government, and what can they do? And it's the immigration policies. And so you're sort of taken aback for a minute, and you realize that, okay, what you're talking about is we need a cheaper labor pool, right? It's not, there's just this tremendous, tremendous investment in the status quo. And part of it is the people who are worried about the shifting money, and Colleen talked about the woodwork effect. Many people are currently paying for things right now that some people are concerned that if the government gave them the money and not the strings attached, they would take it and not pay for it themselves. And then there's the conservative nature of the clinical community around believing that people are safer in a environment we can control, right? And that's impeding the progress significantly. And I think the money issue is almost easier to resolve, and the woodwork issue is easier to resolve because there's lots of levers you can do to ensure that it goes to the people who need it the most, and it doesn't go to the people who don't need it. And when you look at the income data, we have income data on who's in long-term care, and the rich people, even though there's a huge financial incentive and subsidy to go into long-term care in British Columbia, that's not where the rich people are. They're at home, right? So who's in long-term care are the people for whom the ability to come up with the $40,000 or $50,000 a year that it's going to cost to care for their mom at home is just not on. And the only way for them to get a subsidy is for mom to go into long-term care. Now, BC's numbers, which are the ones I know, are always going to be higher because our labor costs are higher than the rest of the country. But here in BC, it costs $84,000 a year to keep someone in long-term care. And that will go up as we increase the care hours and the wages, right? Now, the government pays for, on average, about 60,000 of that, and the resident pays the other 24,000, right, on average. So if we said, further to some of the evidence in the paper where the country's say 80% of what, if we gave families and said to them, we'll give you 40 or 45 or $50,000 a year, the family can contribute some, they just can't come up with all of it. And in the program we do have that's effective, although very, very low utilization in BC CECL, people are employed. There's a requirement when you take this funding that you become an employer, and you have to register with CRA and do CPP and do EI. So there's, some of these concerns, labor force concerns, are ameliorated to some extent by some of the restrictions we put on. But we're just, we're resistant to change, and we've got a lot of different parties for different reasons advocating why we can't change. And I just want to comment ever so briefly on the insurance scheme, because in BC we had medical service premiums that people had to pay, and it became an election issue, and they're gone now. But the long story short, whatever the premiums are that people pay, they have to be progressive. They can't be a flat rate, because if they're a flat rate, which is what our MSP premiums were, you're disproportionately disadvantaging lower income people and rewarding higher income people. So, you know, it's a premium that the premium you pay is based on your income if we went down that road.
Thanks, Isobel. Colleen, you want to get in?
Oh, I just want to say I agree with Isobel about the stickiness of shifting of change. It's always really difficult, and by raising or problematizing cash for care, that's why I was clear. We're not opposed to it. In fact, we're in favor of it, but we just want to make sure that when we're implementing it, that we're doing it carefully and appropriately. You know, as between the two options that we see on the table from Germany and the Netherlands, we think the Netherlands is a better route to go, which is kind of a calibration between genuine worries, I think, about quality, and then, you know, worries about quality that are sort of made up to protect, or exaggerated some to kind of protect the status quo. But I do want to say that I do agree with you that, you know, while we have concerns are raised about quality of care provided by informal care providers, that we also, of course, have very significant concerns about the quality of care that has been provided by formal home care providers, and of course in long-term care settings. Right now they're legend. So one can't assume that because it is professional or centralized, that it is therefore better. So I completely agree with you on that.
Can you speak briefly on that? Because, Ito, you want to get in here, but maybe I can, why don't I let you in quickly, 1 minute, and then I've got one question from the audience that I have to get to.
Okay, so what I was thinking is that I think it seems to me there is not a disagreement, but I think if we were to introduce the cash for care, I think, and I think, Colin, you pointed out very in your report too, is that some form of uniform regulation is really, really important, as Dutch and German model clearly show. Right, that with better regulation on the quality of care, the training of the care worker, who gets the care, how that gets paid, without that, it is sort of very difficult to ensure the kind of quality that we're looking at. And I think that's Isobel's sort of the concern that at least I heard, is that if we don't have that system of regulation, you know, in the case of cash for care, then it is very hard to know what's going on.
Yeah, I think what Isobel's point is, and I'll let Isobel speak for herself, but you don't want to replicate all the problems that we currently have with normal provision, which is over bureaucratized and makes it difficult. So quality of care from an individual care recipient's perspective, that is one aspect, you know, of what they worry about. They worry about the quality of care, but they also worry about timeliness, about getting the thing that they actually need, as opposed to, we'll give you this thing, which you don't actually really need because, you know, that's what we do, and too bad for you, right? So So that's part of the problem. So I think, you know, you have to have some mechanisms to ensure that people aren't being harmed. There's been a whole bunch of questions about elder abuse that we need to have all of those mechanisms in place, but we need to have them anyway, right?
Well, you're a bit, that is the question I wanted to ask. But, you know, why don't, and in Colleen and Ito, why don't you speak to how Netherlands evolved over time to react to questions about care quality, and how they redesign their formulas a little bit to react to care quality in terms of personal budgets and what people could spend personal budgets on. And Ito, at the same time, I'll ask you that, because I know that, you know, Japan over the years as well has had reconsiderations about the cash for care option, and has started sort of not implement it purely, but increment towards it, you know, and so at least some of the advantages towards it. So could you both speak concretely to some of the things that
So
have been
I'll
done?
just say first up that, and there's some examples of that coming in the Q&A, that many provinces have had a kind of cash for care program for non-elderly people living with disabilities. And so folks, you know, younger people living with disabilities able to direct their own care using cash for care. And I think, you know, from what I see, generally this is very well thought of, regarded, and so on. So the problem with older adults is a question of increasing vulnerability. And obviously there's a spectrum, like most of us are fine or will be fine. But some of us, you know, and that percentage increases as we age, will have cognitive and other issues which may make our decision making more difficult. So there is, you know, this problem that not one size fits all. Like a lot of people will be autonomous and able to make choices and direct their own life. But a significant proportion, you know, not insignificant proportion, will not be able to. So how do we make sure that they are protected? And that changes, right? So it's not like you can sift them out at the beginning and say, well, we're going to have all these measures for you and not for anybody else, because people, as they age, there may be cognitive decline, and that will differ over time and space. So I think that's the first thing to note, is that poses a regulatory challenge, right? So how do you deal with that? So in the Netherlands, it's a bit hard to uncouple, you know, what were they doing because of concerns about fraud or elder abuse or quality, and what were they doing because they were worried about the cost of the program. So a bunch of things were done to basically sort of restrict the growth of the cash for care program. But I think the most important thing they probably do is, as I said, is this idea of a sort of centralized contract. So the contract is between the informal care provider and the care recipient, and it really lays out what the informal care provider should do, their duties and responsibilities, you know, the fact that there may be a review of what happens and all these kinds of things. So I think that just sort of sets the scene for that this isn't just, you know, I'm some sort of, you know, historical relationship where I'm caring for you and you need to be grateful. And do what I tell you. You know, it tries to sort of shift it around so that the power lies with the care recipient, even in that sort of informal family relationship. So I think that's I think a very interesting model. Now in Germany, it's different, because the cash for care in the Netherlands came about many years into their long-term care insurance program. You know, it came about because people were brassed off with all the bureaucracy and not being able to get what they needed. Whereas in Germany, the cash for care program was very much a part of it from the get-go. So Germany had this epiphany in the early 90s that they really needed to do something about long-term care for the future. So they brought in this big plan. It was one of the biggest things that ever happened in Germany from a social policy perspective in the early 1990s. And they had cash for care as very much part of it. But, you know, some of the differences here across jurisdictions in terms of the role for women is important to remember. So as I said, many German women only work part-time.
Yeah.
They don't work full-time. And the same is true in Japan. In fact, even much smaller percentages, I understand, of Japanese women work full-time. So that really makes a difference, right, to their ability to participate in informal care markets and how you view that. Because as Ito said, in Japan, one of the worries was, if we put in place cash for care, this will further dissuade women from participating in labor markets. We definitely don't want that, right? We're in a little bit of a different space in Canada, where we would have.
It's a good segue, Colleen. I'm conscious of the time, so I do need to give Ito and Isobel the last word. You know, if you could keep it brief, Ito and Isobel, I'd love to hear some of your final concluding thoughts here and what you'd want to leave people with in terms of your takeaways. Ito, why don't you go first?
So me or Isobel first? Me. Okay. So just going back to your question about care, for example, in Japan, just because they don't have cash for care doesn't mean there's no care other than institutional care. There are lots of care, except that it is provided in service form. And what they have in turn is what they call care manager who, well, each person is assessed due to level of disability, a cash equivalent of services that is held in a cash, what they call sort of care package. And then you work with the care manager to choose which services you want to get. It's just that that money is not coming to you directly. What is so interesting about this is that by having that third person interaction, you could create a kind of labor standard contract and employment system that are nicely regulated, that provides provide regulated kind of services to individuals. Now, having said that, Japan completely refused cash for care directly to the recipient. They realized later on that in some remote regions where regional local governments cannot provide very diverse set of home-based care, they realized that for those people, if they want to get services, people might have to fly in to provide. And so because of that, they're beginning to open cash for care to care recipients so that they could pay their relatives or whoever in the neighborhood to provide care. So there is a move, sort of opening in the special cases for cash for care. Again, I think what it shows is that these things change over time as the social context and demography changes.
Yeah. That's a great, it's a really salient point, that one, I think. Isobel, you get the last word because, we're at time here. So you get to sort of wrap us up and give us your final reaction.
Short, I got that. Okay. So my parting words of wisdom would be this. Cash for care is, as Colleen points out, but one piece of a puzzle. That at the end of the day, for a variety of reasons, some people will have to go to long-term care, and staying at home to receive care will not work. What I think we need to sort out is that for the people for whom the factors are in place that would allow them to remain at home, and those factors include an involved family member, a physical environment that will work, and a community around them that will facilitate their ability to live at home. For that group of people, let us develop a financial system that says, okay, we are going to support you to stay at home financially to the same degree that we would support you, given your income or whatever financial assessment we do, to care for you in long-term care. To me, it is that if we start from that simplest of the base of the program you're going to design, you will find that all of the other things will start to take care of themselves. Yes, the issues will crop up, but they exist everywhere. No program will be perfect. And what I think people like me have had, I hate to say validated because it's a tragedy that has caused it, but this argument around the safety of long-term care. And COVID has revealed that it's not as safe as we think it is, and it definitely doesn't confer immortality. And we are talking about the last years, maybe months of a person's life, and really it's what they want. That the quality, we also have to be very, very careful that we don't project what we think is quality of life onto others. I mean, there's some basics, but for the most part, a case manager worth her salt, or his, can go to that home 4 times a year for 30 minutes and know if it's working or not, period, right? Yeah. And without getting into the minutia of, how much did you ambulate today? How much did you, how many baths, that when you walk into these homes as a practitioner, what, and it looks different. What works, people are different, right? And we need to remember that. So those are my parting thoughts.
It's such a great discussion. I feel like we could talk for so much longer, but I'm happy that this is going to be recorded and posted, because I think people can come back to this and reference it, because there's so many good points that were made. So thanks to you all. Thanks, Colleen. Thanks, Ito. Thanks, Isobel. Thanks for our audience for sticking with us. One thing I would add to Isobel's concluding remarks is that going forward, there's tremendous risk in governments doing nothing. And we know that. I mean, that is unquestionably clear. So, thanks for this conversation. I really think it helps, pave the way forward and give us some good ideas. So with that, I'm going to pass everything back to Ricardo, who's going to give concluding thoughts, and everyone have a great rest of your day.
Thank you.
Thanks.
Thank you all.